The second segment of the bulletin, where we get into our weekly discussions. And on Health Digest tonight, Dr. Mercy Korir will continue that discussion about discordant couples and the challenges and, you know, the milestones. Really, there have been a lot in that direction. And later on, I shall be speaking to Pius Masai, who is the Deputy Director at the National Disaster Management Unit, with regard to disaster response, preparedness, and rapid response, really, in the country. We'll have a lot of conversation in that regard. Right now, I'll hand it over to my colleague, Dr. Mercy.
Thank you very much, and a very good evening to you from wherever you're joining us. And today we discuss the topic of HIV and AIDS, and particularly today we are talking about the CDC report that, you know, for those people who are living with HIV, once their levels are to an undetectable level, then the chances or the likelihood of transmitting to their partners or to their children is slimmer than if they were not taking ARVs or if their viral load was highly detectable. And with me today for that discussion, to my immediate right, is Dr. Abraham Katana. Dr. Katana is the Chief of HIV Service Delivery at CDC Kenya. Dr. Katana has previously been a provincial antiretroviral therapy officer at the Ministry of Health and has also been a CDC technical advisor on the same, with 15 years of experience in public health with a focus on HIV epidemic control in resource-limited settings. He holds a medical degree from the University of Nairobi and a Master of Science in Global Health from the University of Oxford. With me also tonight is Churchill Alumasa. Alumasa is the Executive Director of Discordant Couples of Kenya, that's DISCOC. Since 2005, he's been advocating on issues around HIV, discordance, and safer procreation methods for the couples. He's the immediate former chairman of the Community Advisory Board of the PrEP, which is a pre-exposure prophylaxis study in Kenya. And I will start this discussion straight with Alumasa Churchill. The Kenya AIDS Indicator Survey of 2012 puts the number of discordant couples at about 260,000 in the country. And now with information, though many of you have known that this information about undetectable is equals to unlikelihood of transmission, what does this mean to the 260,000 couples living in a discordant relationship?
First of all, thank you for having me here, Mercy. It means a lot because what I would like to say first, we need to explain to the viewers probably what a discordant couple is. This is a situation whereby when you test for HIV, one partner is HIV negative, the other is HIV positive. Mm-hmm. Now, the biggest challenge for couples since 2005 has been the need to procreate. What happens is when people get married or in a steady relationship, society demands that for an output, they have children. So couples have been taking unnecessary risks just for the sake of satisfying society. But now with the issue of viral detection assisting, ARVs assisting, yes, we knew this for a while, but now that it's in the open, it's going to help a lot of couples who would like to have children in a safer environment to be able to do so.
Mm. Okay, Dr. Katana, how did you've been 15 years in the field of HIV and AIDS, how did we reach to where we are now? What steps and what measures have we put in place that now we can safely see with an undetectable level of the virus, then the likelihood of transmission is reduced?
Yeah, so thank you very much, Dr. Mercy, for having us here today to discuss this very important topic. Just to take a step back is to say that with 1.5 million Kenyans living with HIV, I mean, this is a huge topic, and these news are very great for us as a country because it has a lot of impact around how HIV is viewed. We have made tremendous progress. If you remember, in the late 90s, early 2000s, it was really about testing, and yet we did not have treatment available. And when treatment became available, expanding it using the public health approach with standardized regimens, really helped us to make, tremendous progress in scale up. Getting to the point where we are right now, where we recently surpassed the 1 million mark, of people living with HIV/AIDS, being on the life-saving antiretroviral medicines that, has only been achieved in a few other countries in the world. I think in sub-Saharan Africa only, South Africa. And so just looking at how, the science and program have interfaced, a lot of this data have come from research where, trials have been conducted to really better understand HIV and how things work. And these have followed, program implementation. And we have seen some very good progress in these aspects. We participated, in a number of studies, and, a number of researchers have also conducted multiple studies. And we logically would imagine, because, transmission is really dependent on the amount of virus in circulation. So logically, you'd expect if the virus is suppressed, then the risk of transmission, declines. And as my friend here said, even though that was very intuitive, it took time for the science, the evidence to build up. And we've seen this in the programs for prevention of mother-to-child transmission, where when we've given antiretroviral medicines to pregnant women, that has suppressed the virus, and, that has translated to having HIV-negative babies born by these mothers. And we had a number of trials, including, one of the landmark studies that was enrolling discordant couples and providing the HIV-positive partner with antiretroviral therapy and monitoring the impact that had on the risk of transmission. And Kenya was one of the countries that participated in this, and we saw the reduction of 93%, at the end of it. And more recent studies have actually shown that as long as you have achieved viral suppression, which means the amount of virus in your circulation is low to the point that it's undetectable, then the risk of transmission to your sex partner is almost negligible, which is really, really good news for us as a country.
Okay. So with all this information that has been known among researchers and scientists, why was it not in the public? Because that's one of the major questions people have been asking. Why was it not out there for people to know that this is how it is?
I think from a community point of view, there is some information you don't just let go, because different people like to hear what they want to hear. For instance, people would then say that if viral suppression is equal to not being able to transmit, then they are free to do whatever they want to do. But now the problem therein comes with ARVs. There's a lot of work that goes into it. You have to have the right diet. You have to take your meds at the right time every day, so that within 6 to 9 months, you're able to get to viral suppression. Without that discipline, without that taking your time to do this, you are not going to be able to have that viral suppression. So when you just say that there's viral suppression without the other, whatever it takes to get there, then we would have a problem in the general population.
Okay.
Yes, I would also like to add to what has been said, in the fact that, like I said, the science has been building up. The concrete evidence regarding how impactful undetectable viral load, is in terms of, minimizing the risk of transmission, only became, recently consolidated with the HPTN 052 study, and the more recent studies that have just been published. Number two, in settings as ours, we know that being able to monitor viral load is actually a recent and very exciting development. Previously, in many countries, such as Kenya, we monitor the impact of ARVs or the HIV drugs, through CD4, just looking at how the body is able to mount immunity. And we knew that was not the perfect way, but that was what the resources allowed us. But Kenya has been one of the countries that has, in the recent past, especially the last 3 years, scaled up viral load testing. Technology that was previously available only in the West is now available here in Kenya, thanks to the government of Kenya, but also with partnership, with the US government through PEPFAR and other key stakeholders. So right now, it's when we are comfortable in a position where we are able to do up to 1 million viral load tests a year. So that means you have the capacity to ensure that everyone on treatment has access to this viral load test, and then you're able to make, to provide guidance, as needed. So it's really the science building up, but also a resource issue in terms of us being able to say that with confidence.
Okay. And Just following up on that, we know Kenya reports 70,000 new cases, about 70,000 new cases of HIV in a year. And out of these, almost half, 35,000, are in the age group between 15 to 24 years. Yet there has been a lot put into detection, that is screening and treatment of HIV. And people actually started immediately on diagnosis, they are started on treatment. But then we are seeing all this. We are still reporting new infections, 70,000, and half being in the young group, 15 to 24 years. Why is this still the case?
Yeah, okay. Me, from where I sit, there is the issue of, you're saying 15 to
24 years.
15 to 24 years.
And especially girls are 3 times more likely to contract the virus than boys. Yes.
Okay. This age group, and this is something we talked about, more than a decade ago. Around that time, issues about HIV discordance were kept under the table. A lot of children, the ones we are calling the HIV babies, were born around this time frame you're talking about. So people are just beginning to find out now because there was not a lot of disclosure, probably from their parents and things like that. So from where I sit, I think that could have been the gap that we had. But also, you allude to the fact that, can you say that again? You allude to the fact?
Sorry?
There's something you said about half the new infections.
Oh yes, that it's half the new infections are between 15 to 24 years of age. And out of these, girls are 3 times more likely than boys.
Yeah, those are the statistics. But there are also other issues because that age group is basically students. There's challenges if students are in boarding, whether they'll be able to get to their pills without other people knowing. And also there's peer pressure about you taking pills and you're not sick. So there are those societal issues around that.
Okay. What, from a service delivery point of view, why are we still reporting 70,000 new cases across the country and half being from the youth?
Thank you. Good question. So first, I would like to say that 70,000 is a large number. But again, it shouldn't be lost to us where we've come from, that this is actually way lower than it was even 5 years ago when we were reporting about 100,000, new infections occurring. That said, coming back to the success that I talked about, that we have 1 million Kenyans living with HIV/AIDS being on treatment, it also implies that there are about 500,000 Kenyans who are not yet on treatment. And the biggest barrier is really around, knowledge of HIV status. Many of those not knowing their status and hence not being on treatment. And when you're not on treatment, then you're unlikely to achieve viral suppression. And if you do not achieve viral suppression, you're likely to transmit the virus. Coming down to the issue of, the youth, and especially the young girls, we know that they have been disadvantaged, for a long time in a number of fronts. From a socio-cultural point of view, the issue around economic empowerment. We know about the kind of sex partners they have, that they're likely, young girls are likely to have older sex partners. And as we have looked at the demographics for Kenya, we have seen that older men are more likely to have HIV than younger men do. And so what has been shown elsewhere is that, these young girls engage in sex, with older men, for a number of reasons, including, availability of resources. And then they, in turn, infect, their boyfriends, in a cycle that keeps repeating itself and can only be broken if these girls are actually empowered. There's also the issue of the biological, part of the transmission, where we know the surface area of the genital tract of the females and the ability of the virus to get into their bodies is actually higher. And one thing that is actually both, social and also, biomedical is the issue of violence. We know most of the young girls who have sex, there's a lot of intimate partner violence, some of it subtle, some of it unspoken. And when this happens, then there's more likelihood of, penetration of the virus, through the genital tract.
So now the question would be, what are we doing about it if this group, the youth, are at risk of HIV at this tender age? Is there anything being done about them? Because are they grouped as one of the key populations that are a priority area for HIV?
Yes, so thank you again for that question. You know, one, we know that information is power. And Kenya was one of the earliest countries in sub-Saharan Africa to be able to tease this out and acknowledge that we do have a problem in this population. And if you remember, His Excellency, you know, President Uhuru Kenyatta actually did, you know, highlight this at the launch of the All-In campaign and specifically asked for strategies that help address the HIV burden, you know, in this population. We then went ahead and looked at their data, you know, from testing to treatment to also prevention. And one thing that is very, very obvious at this point is that not all, for example, girls at this age group are at the same risk. We know the ones who are more vulnerable are the ones who are economically disadvantaged. Okay. And so we have several interventions, and one of the most powerful tools that has been shown is about keeping girls in school. And we have, you know, some programs supported by the U.S. government, you know, where we provide support to adolescent girls and young women through the DREAMS initiative to keep them, you know, in school for longer, and also some socio-economic activities to empower the girls to be able to have a better say.
I'll pass the same question to Churchill. 5% of couples are in a discordant relationship. One is positive, one is negative. And are they part of the key populations by the National AIDS Control Council, or NASCOP, for a key priority area in HIV prevention?
Apparently, the government does not seem to think that discordant couples are a key population. They call it a priority population. Yet both Kenya Indicator Survey studies of 2007 and 2012 have shown that new infections, 44%, are likely to happen in discordant couple relationship, new infections. So I think they're doing a new one, I think 2017, but that's the data. So discordant couples should not be as in a key population, it is the key population. When we're dealing with HIV and AIDS, I think we missed the bus somewhere. And where we missed the bus is that we're trying to compartmentalize the fight against HIV and AIDS. HIV and AIDS is a family problem. Family is the basic unit in society. If we can start dealing with HIV from the family level, I think then we will make even better strides to be able to conquer it. So to answer your question, no. Whatever is going on right now, discordant couples are not considered a key population. In fact, to make it worse, there is no single intervention that deals directly with discordant couples, apart from probably PrEP, but that's not an intervention. That's a biomedical intervention. We need to look further into the issues of psychosocial support and things like that, because discordant couples, it's not as easy, especially the negative partner who bears a bigger burden than their positive partners. It's easier for positive partners to be able to walk into a health institution and have an array of interventions. But what of the negative partner? Yeah, right now, service delivery is at CCCs, you know, this comprehensive
care centers.
Yeah, care centers.
Yes.
Now, the problem with the negative partner is that they are averse to going to CCCs, because CCCs are associated with HIV positive people. So these are some of the challenges. So apart from just making it a key population, it should be made one of the main populations to look at, because when we sweep it under the rug, then we might have some problems.
I think I'll take that as your final comment. And for you, for your final comment, do you agree with him about the approach to discordant couples?
Yes, I do. I agree with him about the importance of discordant couples. And one of the things that the program has really focused on, you know, at the national level and also, you know, in all the other aspects is, number one, making sure that sex partners of the people living with HIV/AIDS who are in care are actually tested. So we're able to identify those who are positive to put them on treatment, and those who are negative to provide them with, you know, available interventions. Number two, I would like to say that discordant couples have actually been prioritized for PrEP. You know, right, you know, from the time of the trials to actually, you know, as we implement the program, when we are doing the quantification, you know, the Ministry of Health, they have been prioritized for PrEP. We also actually worked together with the ministry to develop, tools to be able to follow up longitudinally, in terms of being able to provide them with support, including, psychosocial support, having discordant couple support groups, but also testing and other additional biomedical and psychosocial support that they may need. So they are a priority, and we'll continue prioritizing them, including, having some specific resources dedicated to supporting them.
Okay. Gentlemen?
Can I just say something about that?
30 seconds.
30 seconds,
yes.
A quick one. There's always this challenge of, because what they're saying is that they're delivering this psychosocial support at CCCs. I've said it again most of the time. That's where they deliver it, the support groups. Negative partners are averse to going. And you also know that in Kenya, there's this problem of males seeking health services.
Health-seeking behavior in males is quite wanting.
Yes, so I think we need to really work hard on that.
Okay.
Yes.
Thank you so much. And it's coming at a time when you're implementing differentiated models of service delivery, where we are taking HIV outside of the traditional health facility to even having this available at the community level. And I think that is going to change things, for us.
Okay. It seems that we still have a lot to discuss on this topic, but that's all the time we had tonight. Thank you, gentlemen, for making your time to discuss this important topic with me. And today we were discussing the issue of HIV and AIDS, and that people living with HIV who are diligent with taking their medication, once their viral load is undetectable, then their chances of transmitting the virus to their partners is actually slim. And that has been the topic of discussion this evening. And with me was Dr. Abraham Katana, who is the Chief of HIV Service Delivery at CDC Kenya, and Churchill Alumasa, who is the Executive Director of Discordant Couples of Kenya. And that's all we had for you tonight. We can continue this discussion offline. You can tweet me at Dr. Mercy Korir, and we can continue with this discussion. Until next week, do have a good evening and enjoy the rest of your viewing.